Hi everyone. This week we are finally going to begin to assign AJCC cancer staging. And we're going to begin with prostate cases. We will also review the summary stage for prostate cancer during this presentation. And it's been a while since we've reviewed that, so we will review that today. As we begin to use each chapter of the AJCC manual, I'll let you know if there are any updates or corrections to the manual itself, okay? So chapter 58, the prostate chapter, has had no updates or corrections made to for the third printing, which is the version that you have. So nothing to update in this chapter, which makes it a whole lot easier. Adenocarcinoma is the most common histology of prostate cancer that uses the chapter 58 for AJCC staging. Remember from our solid tumor rules, acinar adenocarcinoma is the same thing as adenocarcinoma when it comes to prostate cancer. There is a listing of the WHO classifications of tumor histologies listed on the first 2 pages of the chapter. I'll show you an example of that in a moment. These are the histologies that we would use this chapter to assign the AJCC staging. So depending on the site and the chapter, it will tell us the specific histologies that we use that chapter for. There's also a notation on the first page of each chapter that lists the cancers not staged using that chapter. So for the prostate, and I have a little snippet here of that portion of the first page of the chapter. For this chapter, sarcomas we do not use this chapter for sarcomas. If we would have a sarcoma, we would have to go to chapter 42, and it tells us exactly that. All right, urothelial cell carcinomas, we would use chapter 63. The urethra chapter, that actually includes the prostatic urethra. Okay, the prostatic urethra is just the portion of the urethra that goes through the prostate. Okay, so there's a special chapter for the urethra. If the tumor is a urothelial carcinoma of the bladder and the tumor involves the prostate, then we would have to use chapter 62, urinary bladder. So always double check to make sure that, the histology that you have for your case is listed for the chapter that you're using. And if it's not, it usually tells you exactly what chapter you do need to go to for that type of histology. Because some things are staged by site, but then there are some things, not as many things, but some things are staged by the type of histology the tumor is. Now, this is a couple snippets from the first 2 pages of the chapter, and where it lists the histology codes, okay? So it says the histology codes, it's from the ICDO, and then it goes to the next page, explains, the behaviors and all that. And then these are all the histologies that we would use for the prostate chapter, okay? This is a shorter list, okay? But like I said, almost all prostate cancers are adenocarcinoma, okay? So keep that in mind. And this is, like I said, a pretty short list. There are some chapters and some sites that have a long list. Another thing that you need to, pay close attention to, and that's what they're kind of saying up at the top above the table, is there's no behavior code written behind the codes, just like there isn't in the solid tumor rules manual, because any of these histologies can either be in situ or malignant. So it can be behavior 2 or 3. Okay, and once again, here we have that acinar adenocarcinoma. Remember that adenocarcinoma is the same thing as acinar adenocarcinoma of the prostate. All right, so make sure that when you're abstracting, you always pay close attention to the histologies that are included in that chapter. There are some histologies, if they're not listed there, and sometimes they're just not staged at all, okay? So that's why it's important to really pay attention to that listing. So let's talk about the staging itself, okay? Now, this slide is very, very, very important. So you're gonna wanna keep it handy, all right? The DRE, the digital rectal exam, which we talked about last semester for cancer disease management. So pull out the prostate presentation if you have to. That would be very, very helpful, all right? So the DRE is the primary clinical assessment used to assign the prostate clinical stage. Basically, it's the only information that we really use to assign the clinical T, okay? Now, prostate cancer most often arises like 80–85% of the time within the peripheral zone of the prostate gland, where it can easily be detected by the physician performing the DRE. The clinical T category should always reflect the DRE findings only, okay? If you're abstracting a prostate case and you, the cancer registrar, have no information pertaining to the DRE, you must assign the clinical T, the CT, as blank, and you will not be able to assign the stage group then, okay? There won't be any cases like this in class, all right? But you may run across a case or a few cases, you know, when you're working in a facility that the patient may have been diagnosed and received surgery elsewhere, and maybe they're just receiving radiation treatment at your facility and you don't have that DRE information, and your radiation oncologist didn't include the DRE results in the consult that they did, you know, then we don't have that information, so it has to be left blank, okay? So for clinical T, you're gonna use that DRE to assign the clinical T category, okay? Now, when I say that biopsy information is not used when assigning clinical T, that doesn't mean that you're not using the fact that the histology of the biopsy was positive, okay? Yes, you're using the fact that the biopsy was positive, but beyond that, you're not going to use any other information, whether it's in one side of the prostate or the other or both, okay? And then we're going to use the Gleason score to determine the grade group from the biopsy, okay? But the only information that we're going to take from the biopsy to clinically stage the prostate cancer is that the biopsy was positive, it's cancerous, okay? And then we need to use the Gleason score to determine the grade group, all right? So imaging information should not be used to assign the clinical stage, okay? The TRUS, or transrectal ultrasound, has not been proven to be adequate for predicting extraprostatic extension. All right. So since, you know, the trust doesn't help identify what the extension of that tumor is, we aren't going to use that information, okay, even if we have it. A bone scan may be used ordered for high-risk patients, and those high-risk patients are patients that have a PSA of 10 or greater than 10. A high PS level of 10 or greater can be an indication that the patient has bone metastases. And then a bone scan will be able to prove or disprove that, okay? But once again, that bone scan, yes, we would use it, but a positive bone scan would actually be used to assign the clinical M category, not the clinical T category, okay? So the only imaging that we can use to assign the clinical stage would be a CT scan that shows distant metastatic disease, or a bone scan, which would show or could show distant metastatic disease to the bone. Bone is the most common metastatic disease for a prostate primary, okay? When the book states that imaging should not be used to assign the clinical stage, this means when it comes to the primary tumor extension, okay? Not to the distant metastases by CT scan or bone scan, all right? Remember from our cancer disease management course, the DRE is the most accurate way to determine the clinical stage of the primary tumor for the prostate. So that DRE is very, very important information when assigning the clinical T. To assign the pathological stage, you use all the clinical information that you have, plus the operative report information provided by the surgeon and the surgical resection examination provided by the pathologist, the pathology report. Okay, so remember that illustration. You know, it shows you what information you use to clinically assign and what information you use to pathologically assign something. Make sure that you always have that illustration handy so that you can easily remember what information it is that you can use. Now, to assign the pathological stage, a prostatectomy or a biopsy proving a T3 or a T4 lesion and lymph nodes must be removed. Okay, so you either have to have a prostatectomy, surgical resection of the prostate, or a biopsy proving the tumor to be a T3 or T4 and lymph nodes, okay? So that is the criteria in order to assign a pathological stage, all right? An example of a biopsy proving a T4 lesion would be when the prostate tumor is growing into the rectum and there's a rectal biopsy that proved to be prostatic adenocarcinoma. Okay, so that's, I believe that the T3 would be a positive seminal vesicle biopsy. The tumor was invading into the seminal vesicles. Okay, so just remember that those are the requirements to assign pathological staging. All right, now if they do a prostatectomy and do not take lymph nodes, you would assign the pathologic T, but the pathologic N would be in X. Since no lymph nodes were removed, then the lymph nodes were not histologically assessed. So then you would have to do a PNX. Now, a little bit more about when there's no information about the DRE, okay? Then we once again need to leave the CT category, the clinical T category, blank. If we would assign TX, that would mean that the physician did not know the extent of the primary tumor, okay? Or they did not assess it, or it could not be assessed, okay? So X is basically saying when we assign a TX in the data field, clinical T category data field, that means that that information was unknown to the physician for whatever reason. They couldn't determine it, they couldn't assess it, okay? But there was a DRE was done, okay? The physician just doesn't know what the extent is, okay? Now, there are times, once again, as I just stated, that we might, as cancer registrars, not have that physician information. We may not have the consult or office visit where the DRE was done, or the surgeon doesn't state in the hospital medical records what the DRE results were, okay? If we do not have that information, it's blank because we do not have the information is unknown to us, okay? And why is this so important? Well, when investigators look at the NCDB data, we need to think about how the data looks when reviewed by them, okay? So a TX means that the patient's tumor could not be assessed by the physician, or physician could not determine the extent of tumor, okay? So if we don't have the information and we would put a TX, but we really had no information, the investigators are looking at that, and then in fact that's what happened. The investigators were like, why are there so many TXs, you know? And you know, so they want us to put a blank so that they know that it's not that, you know, the physician didn't know what the clinical T was, it's that we don't know it, okay? And then that way they are making sure that their cases are sorted in the correct way, okay? So even though we do not have the information, that doesn't mean that it was not done. It doesn't mean that it wasn't assessed, okay? So blank means that we, the cancer registrar, did not have the information. So you're gonna wanna keep these, this concept handy, okay? It may not happen often, but it's something that has just come to light in the past couple of years. So there's a lot of education going on right now about this issue. So I just want you guys to learn it from the beginning. So a little anatomy refresher for the prostate gland. Now the seminal vesicles are above the prostate gland, and then the prostatic urethra, like I stated before, it goes through the prostate, okay? But it's still the urethra, okay? And then we have the apex, which is on the bottom, and then the base is at the top. I know, I don't know about you, I think of the base, something being on the bottom, so I need to always keep in mind when the urologist states that, you know, where the abnormality is located. You know, it's not so much that we have to have that information or require that information to assign the T. You know, it doesn't matter if it's the mid, apex, or base but it's just nice to be able to visualize that, in your mind. Um, when staging a prostate case, especially when they're doing that DRE, the physician will talk about the left side and the right side, okay? However, that does not mean that the prostate is a paired site. It is not a paired site, okay? But there is a left side and a right side to the prostate gland. It's one organ. There's just a right side and a left side, all right? Some physicians may call them lobes, the right lobe and the left lobe, but technically they really aren't lobes, and they're just considered right side and left side. There's actually more than 2 lobes in a prostate gland, but right now we just need to understand that there's a right side and a left side, and the prostate is not a paired site, all right? Another note to remember is when a prostatectomy is performed, the seminal vesicles are removed as part of that procedure, okay, and is not recorded in the surgery of other site data field, all right? The seminal vesicles, that's part of the prostatectomy, all right? So since it's part of that procedure, even though, the prostate is the prostate, the seminal vesicles, they just automatically remove with the prostate, so that isn't additional surgery to a regional site, okay? So that surgery to other site, distant or regional, that if it's just the prostatectomy and the lymph nodes are removed, that is coded as 0. The seminal vesicles are part of the prostatectomy. All right, now for the prostate cancer cases, there are separate tables for the clinical and the pathological T categories. So we need to make sure you reference the correct table, okay? Very, very important, and it's so easy to look at the wrong table. Some sites have 2 tables and some sites only have 1. So it's really, really easy to be looking at the incorrect table. So prostate has a clinical T table and a pathological T table, okay? So this is the clinical, and TX is primary tumor cannot be assessed, okay? As long as a DRE is performed, you should be able to assign the clinical category, all right? T0 means there's no evidence of a primary tumor, all right? This would only happen if the patient had a prostatectomy and there was no cancer identified, but the patient had positive lymph nodes, okay, or positive distant mets, okay? I've never had this happen. I've never had a case like this, okay? So I would say that the chances of you running into that are very, very, very slim. So do not ever assign T0 in class, because none of your cases will have that, okay? So very seldom do we ever use category T0, whether it's clinical or pathological. We do use it for post-therapy, but other than that, it very seldom happens in pathological or clinical T. Then we have T1, clinically inapparent tumor that is not palpable. Okay, so this means that the DRE is negative or not abnormal, okay, in a way that would indicate prostate cancer, all right? So if there's an abnormality that, like in enlarged prostate, well, in an enlarged prostate, there's lots of reasons why a male might have an enlarged prostate. Just because they have an enlarged prostate does not mean they have prostate cancer, okay? So these abnormalities are the physician will be like, they're consistent with cancer or make it suspicious for prostate cancer. All right. Now, T1 is the umbrella category or the NOS category and should only be used if you cannot determine the specific subcategory. All right. So this concept is very, very important. Only use the umbrella category of T1, T2, T3 for this table if you cannot assign T1A, T1B, or T1C. All right, so when you assign any type of subcategory, whether it's the T, N, or M, always go to the subcategories first and read through them. Now, because the definition of a T1 or T2 or T3, whatever that NOS code is basically gonna say, have the same information that's in T1A, 1B, and 1C, okay? So everything, T1A, T1B, T1C, would all fit in T1. It's a NOS code. So that T1 includes all three of those categories, okay? So it's very, very, very important to make sure that you just don't assign the umbrella code. You want to, or umbrella category, you want to go down to the sub-site or subcategories, sorry, blanked out there, subcategories, and assign one of them, okay? Shouldn't use NOS categories unless we have to, all right? So T1A is specifically tumor incidental histologic finding in 5% or less of tissue resected. What you should do in your book is open to that page, and behind T1A and T1B, so the T1A is finding in 5% or less of the tissue resected, and T1B is more than 5% of the tissue resected was cancer. Now, these are findings on TURPs or TURPT, okay? So the transurethral resection of the prostate, okay? So TURP can be done for benign reasons, okay? And when it's done for benign reasons, but then they find cancer, that's called an incidental histological finding, okay? So a T1A, T1B, the patient would have to undergo a TURP for non-cancerous reasons, okay? So those two codes are actually not common to assign, okay? So keep that in mind, and I would write behind the tissue resected, put in parentheses TURP for both the T1A and T1B, all right? Then the T1C is tumor was identified by needle biopsy found in one or both sides, but not palpable, okay? Now, remember when I said that you don't use the biopsy information to assign the clinical T? Now, if the patient has a normal DRE, okay, but the biopsy shows that whether it's on one side or both sides that the biopsy is positive, then this is the subcategory that we're going to use, okay? So if a patient has a negative DRE, but their biopsy is positive, this is what you're going to assign it, okay? So when we get to the T2 and higher categories, that's when there are abnormalities to the prostate itself, okay? The tumor is palpable, okay, and confined within the prostate, okay? So here we have T2A. Okay, once again, the T2, that's an umbrella category, all right? So T2A is tumor involves 1/2 of one side or less, okay? Either 1/2 or less of the right side or the left side, all right? T2B is the tumor involves more than 1/2 of one side, but not both sides. So once again, more than half of the right side or half of the left side is involved with an abnormality. That's palpable, nodule, mass, things like that, all right? And then we have T2C, and that's the tumor involves both sides. Now, when you have a negative DRE and a prostate biopsy that has positive biopsies on both sides of the prostate, you do not, I repeat, do not assign T2C, okay? Because your DRE was negative, okay? So if your DRE is negative, you do not go past T1C, all right? So you might want to draw a line right above the T2 and say above is normal DRE, below the line would be abnormal, all right? T3 is once again the umbrella category, both, both you'll see here, extraprostatic tumor that is fixed or does not invade adjacent structures. Okay, so here you have extraprostatic extension. Here in the umbrella, we have extraprostatic tumor, all right? T3B is tumor invades seminal vesicles, okay? And that's specific, okay? So you should always be able to assign T3A or T3B, especially if the surgery was done at your facility and you have that pathology report, okay? You have the pathology report, you can assign, you know, if they're, and once again, you know, that would be those needle biopsies as well, could be assigned for this because it's a clinical table. Okay, so we're not talking pathology report from the prostatectomy itself, all right? And then, so then we have T4, and this is where the tumor is fixed, okay, or invades adjacent structures other than the seminal vesicles, external sphincter, rectum, bladder, the ligator muscles, and or pelvic wall. Okay, so to assign a T4, it would be fixed or invades other than the ones listed here. So make sure that, you know, you pay close attention to those keywords. You might want to underline other than or highlight other than those, okay? Because here, you know, that information would be above that, okay? So that's the clinical T categories. And yes, I know this is very, very overwhelming, but you just have to, every time you do a case, you'll read through these. Okay, it's not like you can memorize them or absorb everything, you know, especially working with many different sites. You just have to read it every single time you do a case. So this is the pathological T category, the PT, all right? So for pathologic PT2, for the clinical, they did T2A, T2B, T2C, okay? Well, looking at the old data, it didn't matter if a patient was T2A, B, or C, okay? So pathologically, there's only a T2, and that's where the tumor is confined to the prostate. It doesn't go beyond the prostate, okay? T3, that's an umbrella category, all right? And T3A is extraprostatic extension, and it can be one side or both sides, okay? Or if there's microscopic invasion of the bladder neck, okay? And since it's microscopic invasion, this information can only be given to you from the pathology report, all right? And then T3B, invasion into the seminal vesicles, all right? T4, same as the clinical T4. Tumor is fixed or invades adjacent structures other than those listed, all right? There's just a couple of notes. We always have to make sure that we pay close attention to any notes that are listed. And one is there is no T1 classification, okay? So that's why it's not listed. The second note is positive surgical margins should be indicated by an R1 descriptor, okay, indicating residual microscopic disease, okay. So basically, we don't assign the descriptors, okay. The physicians can, we do not record that, but they're basically stating that positive surgical margins doesn't have anything to do with the staging, okay? If the physician doesn't get all the way around the prostate, okay, they might not, get outside of the capsule. So just because something has positive margins, the prostate has positive margins, does not mean that the tumor went through the extraprostatic extension through that, past the capsule of that, okay? So that's the pathological T. But you see how different the two tables are, and that's why it's very important for us to make sure we're on the correct table. Then we have regional lymph nodes category, okay? So it's the clinical and the pathological lymph node category is the same table, so that's good, okay? There's TX, regional lymph nodes cannot be assessed, okay? And 0, no regional lymph nodes are positive. And 1, there's 1 or more regional lymph nodes that are positive. So lymph node category for prostate is very easy, positive or not, all right? Now there's a couple things that we need to note when assigning the clinical N, all right? Imaging is not required to be done to assign a CN0, okay? It's just not required. If the urologist performs a prostatectomy, that means, even if they don't write it in the medical record, that means that they believe that the lymph nodes are clinically negative, okay? And how do we know that? That's because physicians, urologists, they're going to follow standard of care, okay? And the NCCN guidelines state if there are clinically positive lymph nodes for a man that has prostate cancer, you would not perform a prostatectomy, okay? So if the urologist is performing a prostatectomy, that means that they believe and they are stating that the lymph nodes are clinically negative. So we would assign a CN0, even if there's no CT scan done, okay? So it would not be a CNX. You would assign a CN0, okay? Very, very important note to remember. You might want to put a little note like that in your book. Then we have distant metastatic category, the M. All right, so M0, that means no distant metastases. Then M1 is once again that umbrella category, okay? Then we have the subcategories of M1A, which means that non-regional lymph nodes are positive, or distant lymph nodes, all right? M1B means that there's mets to the bone, all right? M1C is there's another distant site with or without bone disease, okay? So what they mean by other sites is other than distant lymph nodes, okay? So other sites, lung, all right, liver, all right? And whether there is positive bone disease too or not, it doesn't matter. You assign M1C, okay? Just because that's the worst prognosis, okay? So clinical metastatic disease to the distant lymph nodes and to the bone, you would assign a CM1B, okay? All right, so let's say there was clinical metastatic disease to the bone, okay? But it was histologically proven by a positive biopsy that there was disease to a distant lymph node, okay? Because there was histological confirmation of a positive biopsy of that distant site, you're going to assign a PM1B, okay? Because there was mets to the bone, okay? So we want to take the worst category. Even though it was the M1A that they biopsied, it doesn't matter. We do a pathologic M1B, okay? It's going to take a while to get used to, but just keep this handy for when that case, that type of case comes along, okay? Even though the bony mets was clinically identified by a bone scan, doesn't matter because pathologically, histologically, they prove that non-regional lymph nodes were positive. So we assign a pathologic M1B, all right? So if there is a biopsy of a distant site and that's proven to be cancerous, okay, that is assigned as a PM1 whatever, all right? All you need for a pathologic M is a biopsy of the distant site. All right, so there's other information that we are required to use to assign prostate stage, okay? So there are two prognostic factors that are required to assign the prognostic stage group for prostate cancer. And remember that in the United States, we have to use and assign the prognostic stage group, not the anatomic stage group, okay? That's more for third world areas where they don't have the capabilities of doing these tests. So the first prognostic factor is the PSA. And this is important because the higher a man's PSA level is, the greater the risk he has of being diagnosed with prostate cancer and a greater risk of dying from the prostate cancer. Okay, so that's important for that. And then the other prognostic indicator is the grade group or Gleason score, okay? So the grade is prognostic for PSA recurrence as well as prostate cancer mortality, okay? So the grade group or Gleason score is not only prognostic to identify risk for PSA recurrence, but also from the patient dying from their prostate cancer. So now, what does it mean to have a PSA recurrence? So after a man is treated for prostate cancer, the PSA should go to 0, or what they call nadir, all right, if he has surgery, all right? If he is treated with radiation, the PSA should go to nadir or be 0.5 or less, okay? It might not get all the way to 0. Just because when they do radiation, the prostate tissue is actually still in the body, okay? So that's why there might be a little PSA detected. If the man's PSA increases after treatment, whether it's surgery or radiation, this could mean that the patient has a PSA recurrence, all right? So when PSA, continues to rise, I believe it's like 3 consecutive times, they'll probably do imaging, okay? But if imaging is performed and it's negative, where they don't identify any disease, this usually means the man has a recurrence, but the disease is not detectable yet by imaging, okay? However, it is most likely microscopic disease, since the PSA is rising and is no longer at 0 or nadir. Okay, so that's what they mean when they talk about PSA recurrence. They only know that the patient has prostate cancer in his body because the PSA has risen, but when they do imaging, they can't see where that cancer is. So as stated just a minute ago, the histologic grade of prostate cancer is important for prognosis. This is the grade group table that is used to assign the prognostic stage group, okay? Take the Gleason pattern from the pathology reports to determine the patient's grade group, okay? We'll take the Gleason pattern, okay, Gleason score from the biopsy and figure out the grade group, our clinical grade group, okay, from the biopsy to assign the clinical prognostic stage, okay? Then we'll take the Gleason score, Gleason patterns from the surgical resection or the prostatectomy to assign the pathological grade group, okay? And then we would use that grade group to assign the pathological prognostic stage group, okay? So you'll figure out 2 grade groups, the clinical and the pathological, if the patient has surgery. So a reminder, if the clinical Gleason pattern is higher than the pathological Gleason pattern, you must use the clinical grade group to assign the pathological prognostic stage group. So this aligns with how we assign the grade in the grade data fields, okay? Remember, if the clinical grade is higher than the pathological grade, we have to assign the clinical grade in the pathologic grade data field. Same thing here. If the clinical grade group is higher than the pathological, we have to use that grade group when we assign the pathological prognostic stage group. And that's less complicated than it sounds when you actually do it, all right? So here is the prostate prognostic stage groups, okay? The one thing nice about the prostate is there is only one prognostic stage group table. Some have clinical prognostic stage group and a pathological, but prostate only has one, so it makes it less complicated, all right? So You do have to be very careful when assigning the prognostic stage group for the 8th edition when the patient has a low PSA and low grade, okay? The T category lists both clinical and pathological categories and subcategories in the same table and the same rows, okay, as seen here. First we have the clinical, then we have this PT2, and then C, just C2, CT2B through C, after we have pathological, and then we have this one where there's clinical T's as well as pathological T's, okay? So you may want to highlight the C and the P in different colors to make sure you use the correct one. But it's very important to really pay attention to, the clinical and the pathological. All right, they're all intermixed. So these, it has to be specifically, a clinical or pathological. When we get further down for the T1 through T2 and down, then this is either clinical or pathological, okay? So just, really pay close attention. This is where attention to detail really, it matters, okay? So then we have the T, so we find the T that we have, then we find the N that we have, and as you can see, it's N000, N1. So if you have a T and an N1 and an M0, you'll get to do this quite easily, because there's only one N1. So you would go any T means any T, T1, 2, 3, 4, and anything in between. N1, M0, and then it's any PSA, any grade. It doesn't matter when the patient has positive lymph nodes, and then they're stage 4A, okay? So just follow the table as they have it. When T is, find your T, and N is, then, when you find your T, then find the N, all right? It might be, multiple choice here. And M is multiple choice. And then you get to the PSA, okay? So here we have the first 3 PSAs have to be less than 20, okay? And then it goes less than 20 and then greater or equal to 20. But what makes these, because all of these 6 here are, or 5, I guess, these 5 are less than 20, but you'll see that the grade groups are different. 1, 2, 3, 4, okay? So you can see how everything can be the same here, but when you get to the different grades, then you have different stage groups, okay? So, except here, grade 3 and grade 4 are both 2C, okay? So just, do the M, find your PSA, find your grade group, and then this is what you assign, okay? So, it takes a while, but I have to say that I was quite surprised when they did, when the T is and the N is. So, they really walked you through that. And for a textbook that they literally wrote, for physicians, I thought that was pretty cool. So, and then note, when either PSA or grade group is not available, grouping should be determined by T category and or either PSA or grade group as available, okay? In class, you'll have all that, so shouldn't be a problem assigning any of the stage groups, all right? So that is how you assign the prognostic stage group. rulers are pretty good to, use to keep everything in line, especially because, these tables, the lines are white. So it is nice to have, if you can have one of those smaller, like I think there's 6-inch rulers, or maybe they're even shorter than that, so that, they're not longer than your book page. But so that is AJCC staging for prostate. So just as a quick reminder, summary stage. So summary stage 0 is in situ or non-invasive prostate cancer, which you will never have to assign since these are not reportable cases for cancer registrars. So you will never, ever have to assign a summary stage 0, okay? It's there because it can happen, but we're not gonna have to assign it because that won't be a case for us to report. Then we have summary stage 1, localized. The tumor is confined to the prostate, okay? This includes a tumor that invades the prostatic capsule, but the tumor does not go beyond the capsule, okay? So invasion into, but not beyond prostatic capsule, all right? If the pathology report states that there's extra prostatic or extracapsular extension, you know it's no longer a localized tumor, okay? Because a localized tumor does not have extracapsular or extraprostatic extension, okay? It has to be confined to the prostate. So localized for prostate is pretty simple. Then we have summary stage 2, all right, regional by direct extension. The tumor has grown beyond the prostate, past that capsule wall, and into these structures or organs listed, all right? So here we have extraprostatic, extracapsular extension, okay? It doesn't matter if it's unilateral or bilateral, or if the pathologist doesn't state whether it's unilateral or bilateral, it doesn't matter, all right? So that is regional by direct extension only. Then we have regional lymph nodes. The lymph nodes are positive, but the tumor is still confined to the prostate, okay? So 3, regional lymph nodes only involved, no extraprostatic extension. And then we have the summary stage 4, regional by both direct extension and regional lymph nodes are positive for cancer. Actually, they're positive lymph nodes for prostate cancer isn't very common. I've only ever had a few cases where there were positive lymph nodes. Many times the prostate cancer will metastasize to distant sites without, being evident in the lymph nodes. So just be aware that positive lymph nodes aren't that common. And then, of course, we have summary stage 7, metastases to distant nodes or to distant organs. Now, 2 things to note here. Oh, they took it away. There used to be, that's right, they took it away from this new edition. They used to include the old staging system. That's right. So nothing to ignore there. It's no longer there. Only the direct extensions that would be considered SEER stage or summary stage 7 disease are listed here, okay? All other sites and organs such as bone, liver, lung aren't listed, okay? Remember that not all the distant sites are going to be listed under the summary stage 7. Excuse me. So just remember that everything is not going to be listed here, okay? Bone is, but liver isn't, lung isn't, okay? So it's not an all-inclusive list, all right? And just, you can pretty much think, what would be distant from the prostate, okay? So if it's not listed in the regional direct extension, then it's distant. All right, so now what you should do if you haven't already, stop the presentation and do the next 2 case studies, all right? Just do your best. This is just a way to read through everything and practice, okay? And then we'll come back and we'll do the cases together and see how well you do, okay? All right, so this patient has an elevated PSA of 12.3. The physical exam, the DRE, demonstrated a large nodule occupying most of the left side of the prostate, all right? The transrectal ultrasound with a prostate biopsy was done. And the biopsy identified that there was bilateral adenocarcinoma, meaning that the adenocarcinoma was in both sides of the prostate. Gleason pattern and score was 3 + 3 = 6, which is a grade group 1, okay? Now, some pathologists might give you that grade group, some might not. So you might have to figure it out yourself. You would go to that grade group table and just figure it out yourself, all right? Patient went on to have a radical prostatectomy with bilateral node dissection, which once again showed the bilateral adenocarcinoma. Gleason 3 + 3 = 6, once again, grade group 1. The tumor invades into the right seminal vesicle. Margins are negative and 8 lymph nodes are negative. So our clinical T, here I have the clinical stage table here for us to look at. All right, so the patient had the DRE demonstrated a large nodule occupying most of the left side, okay? So you would have gone to the clinical T table of your manual, okay? And you should have came up with CT2B. Now make sure you include the C in your answer, okay? Because sometimes we can use a P in the clinical data field and sometimes we can use C in the pathological data field, all right? So that's what we always have to assign the CT2B, okay? You're always going to include the CT, CN, CM, and then whatever the category or subcategory is, okay? So a prostate tumor that is more than half of that side, because it occupied most of the left side, so most of the left side is more than half. So that would be a clinical T2B. So clinically, the patient went on to have a prostatectomy. So that means that the physician felt his lymph nodes were negative, even though they didn't do any imaging. And then there was no clinical evidence of distant metastatic disease. So it's this clinical M0, all right? If the physician doesn't mention distant disease at all, that means they don't have any, okay? Remember, you can never, 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 never use MX, all right? If the physician doesn't state anything about distant metastatic disease, then there is none, all right? So now we have the T, the N, and the M. So we go to our table and we find the clinical T2B, N0, M0. The PSA was 12.3, which is less than 20. 3 plus 3 equals 6 is grade group 1. So our stage group is TA, 2A. Now, when we enter the stage group into the software, we do not use Roman numerals. We use the numerical 2, 3, 4. 1, 2, 3, 4. All right? So even though they're giving it to us in Roman numerals, we have to assign it as a 1, 2, 3, or 4 as the number, okay? Keep in mind that the letters for the T, N, and M are almost always lowercase, all right? The stage groups are capitalized letters, all right? Now, Schoology might not mark that incorrect if you have it incorrect, but I will go back and do it incorrect, all right? You have to do it the way that the software, oops, fingers got crazy there. The software is, okay? So our second case, or this, then we go on to our pathologic stage, okay? So we're gonna use all the information from our biopsy, the DRE, and the prostatectomy. So the grade was both for the clinical and pathological. So that's easy, all right? So the patient had bilateral adenocarcinoma, but the right seminal vesicle was positive for cancer. So that is a pathological T3B. Seminal vesicle, at least one, is involved, T3B. We have to add that P in front of it, all right? Then there were 8 lymph nodes that were removed, but they were negative. So P and 0 because they removed lymph nodes, P and 0. And then C and 0, all right, because the patient does not have distant metastatic disease. Okay, remember you cannot assign a PM0. There is no such thing as a PM0. So we go to our table, same table as the clinical. So we go to T3B. So when it says T1 through T2, that means all the subcategories of both. Same for T3 to T4. We have N0, M0, all right? Doesn't matter for this T, N, and M what the PSA was, doesn't matter. It can be grade 1 through 4, which we had a grade group 1. So our patient stage group is 3B. So once again, use the numerical number 3, capital letter B. So summary stage. So we have regional direct extension because it's the seminal vesicle was involved. 1 or 2 doesn't matter, okay? So our summary stage for this case is 2, regional by direct extension only. So case study 2. So this patient had an elevated PSA of 8.14, all right? Physical exam, the DRE demonstrated the prostate to be more enlarged on the left side compared to the right. The prostate was rubbery and soft, all right? So with the elevated PSA and this questionable DRE, they do a biopsy, all right? The biopsy demonstrated adenocarcinoma, Gleason 3 plus 3 equals 6, which once again is that grade group 1. And there was only tumor in the right lateral base. Okay, so not a whole lot of cancer in there. All right, and low grade group. So that's good. So a patient actually ended up having a prostate cryoablation. All right, so going to go ahead and assign the clinical T. Now, what we have to keep in mind is what abnormalities indicate cancer, okay? And one side more enlarged in the other side, that does not indicate cancer, all right? A prostate that's rubbery and soft does not indicate cancer, okay? So this would be considered a negative DRE. It's negative DRE because it's negative for cancer, okay? There's no indication from that DRE that the patient has cancer. So the DRE is negative for cancer, all right? So when we assign the clinical T, it's a clinical T1C, okay? The patient had a normal DRE, but biopsy was positive, all right? Patient, no indication of lymph nodes being positive, so it's a clinical N0. All you have to have is an examination to assign an N0, and that is stated in chapter 1 of AJCC manual, okay? And then clinical M is CM0, okay? There was no indication, nothing indicated by the physician that the patient had metastatic disease. So we go to our table, we find the CT1C, all right? Then we have N0, M0. The PSA was less than 10, it was 8.14. Our grade group was 1, so our stage group is 1. So stage 1, just the number 1. All right, so pretty simple one. All right, actually the negative DRE and the positive biopsies, they're really actually pretty simple to assign because it can only be a clinical T1C. All right, so now we go with pathological stage. Now, remember in the beginning of the presentation, what was the requirement for us to assign a pathological stage? The patient had to have a prostatectomy or a biopsy proving T3 or T4 and lymph nodes removed. Well, none of that happened, okay? So if it did not happen, if the patient did not meet the criteria for pathological stage, then your PT is blank, your PN is blank, your PM is blank, okay? And then your stage group is 99, okay? It's not X's, because if we put X's there, that would mean that the patient had a prostatectomy, okay? Because the patient did not have a prostatectomy, these data fields, the T, N, and M must be left blank. Yes, for Schoology, you're gonna have to type in the word blank, all right? Yes, the software, you would just leave it blank, but you need to type the word blank in for your Schoology assignment. And then we cannot leave the stage blank, all right? So we have to assign a 99, unknown, okay? So pathological staging is really easy when the patient doesn't meet the criteria to pathologically stage the case. So it is as simple as that. If your patient does not have a prostatectomy or a biopsy proving T3, T4, and lymph nodes removed, it's blank. all right? Now, if the patient had a prostatectomy but did not have lymph nodes removed, then you would assign the pathologic T, whatever the prostatectomy says. But you would do a PNX because no lymph nodes were assessed during that prostatectomy. Okay, so keep that in mind. Okay, and we'll get, you'll get practice doing that. All right, but once again, if they're all blank, you have to do 99 for this stage. So summary stage. So this patient, they had a negative DRE, so that means it's clinically apparent or inapparent tumor. Okay, so this patient actually had an inapparent tumor. Okay, because they did not feel it. The physician could not feel it. All right. So this one is assigned summary stage 1, localized. All right, as simple as that. So to do, read chapter 58 and complete the assignment. All right. So for your assignment, you will assign the clinical and pathologic AJCC stage and the summary stage for each case. All right. For these cases, the patient did not receive any neoadjuvant therapy. Okay, with prostate cancer, neoadjuvant therapy really is not done. So for this assignment, you will not have to assign the post-therapy clinical or post-therapy pathological stage, okay? Because you would leave them blank in the software. So I'm not gonna make you write blank for all that. So for this week, because none of these cases really ever received neoadjuvant therapy, I'm not gonna have you assign that, okay? If you have any questions or difficulties, please post them for me, okay? If, hopefully you've listened to this before our meeting for study group, so you can ask questions then as well. And remember that getting frustrated is only going to make learning this more difficult. So if you find yourself struggling and getting frustrated, contact me, make an appointment, okay? It's okay to ask for help. This is difficult stuff. This is not easy stuff to learn. So please don't hesitate to contact me, okay? And happy Halloween. Guys, have a great day.